So hi, my name is Elizabeth Maginot. I'm a resident at the University of Nebraska in Omaha. I work in Chris's lab. And I'm going to be presenting some work on plasminogen supplementation improves lysis of inflammatory retained traumatic hemothorax that we did in conjunction with our colleagues at Denver Health. All right, I have nothing to disclose. To start, let's kind of define retained hemothorax and talk about what it means clinically. So retained hemothorax refers to blood that accumulates in the pleural cavity that is not effectively drained after 72 hours. It can occur typically after trauma or surgery. And then it's clinically significant because if left untreated or inadequately managed, it can lead to complications such as empyema, lung entrapment, or chronic pain, and really just leads to higher mortality or morbidity overall in these patients. How we standardly treat this is we're going to place a chest tube and then administer or either do surgery or give interpleural lytic therapy, which we've discussed a little bit, which is TPA plus DNase twice a day over the course of 3 days is how it's standardly administered. However, this kind of prolongs actually getting to surgical management if that's what the patient needs, and there's a pretty high failure rate of about 20%. So 1 out of 5 patients will fail this therapy, leading to extended hospital stay and then eventual need for surgical intervention. Diving into some of the pathophysiology of retained hemothorax, we know that it creates an inflammatory environment in the chest, and then this inflammation leads to the release of proteases, such as neutrophil elastase, which can degrade proteins critical for clot breakdown. One of these key proteins is plasminogen, which I'm sure none of you guys have ever heard of before, which, as we discussed extensively this week, is essential for fibrinolysis. So plasminogen, when activated by TPA or UPA, is converted into plasmin and then degrades fibrin into soluble fragments. However, in inflammatory environments, the proteolytic activity can deplete plasminogen before it's activated, reducing the amount of plasmin available for effective clot breakdown. So the aims of our study, we had a few questions we wanted to answer. So first is is the retained hemothorax, to investigate the markers of complement and fibrinolysis in retained hemothorax. We also wanted to determine if the retained hemothorax environment was actually as pro-inflammatory as described, and then to investigate if plasminogen supplementation improves the efficacy of TPA-mediated fibrinolysis in these patients. So can we rescue that inflamed environment? We did this by collecting hemothorax fluids from 16 patients as well as their corresponding plasma samples. And then we ran assays for complement activation markers, complement regulator markers, and then inhibitors of fibrinolysis, and so on and so forth. We also performed turbidity clot lysis assays, where we mixed our hemothorax fluid with human thrombin, fibrinogen, and then recombinant TPA. And then we had we supplemented with plasminogen in some of the groups to kind of see how much the lysis would happen over time. Okay, so on to our results. So here we have our results of our inflammatory markers. So we are comparing our hemothorax samples on the left to our plasma samples, or the left dots to our plasma samples on the right, and then we can see that there are higher levels of C3A, C4A, and SC5B9 in the hemothorax samples compared to our corresponding plasma, leading to a pro-inflammatory environment, and then low levels of the regulators, so factor H and factor I in comparison. So not only is it pro-inflammatory, but there's not a mechanism to actually turn complement off. Do keep in mind, though, we did not have a super high patient sample, so we only had this done in 3 patients, so we need to kind of expand that further, but even this data is interesting to look at. And then, so this inflammatory environment that's created by the hemothorax really leads to neutrophilic inflammation, which we saw as well when we tested for elastase antigen levels, which were significantly higher in our hemothorax samples in comparison to the plasma. These findings are really crucial because they indicate a highly inflammatory environment, which increases the protease activity, and then the level of inflammation can degrade plasminogen and then hinder fibrinolysis down the road. So you're not going to drain your big blood clot in your chest. Another thing we looked at was active Pi-1 in hemothorax, and we looked at this because traditionally this was what was described as the reason why you needed multiple doses of lytic therapy for adequate drainage with the TPA DNase. And we did observe that active Pi-1 was higher in hemothorax fluid in comparison to corresponding plasma, which we think is consistent with that inflamed environment that I described before. But it is important to note that our experiment revealed that even a very low dose of TPA, as small as like 330 picomolars, which is 3 orders of magnitude lower than what we typically use clinically, completely suppresses the detectable Pi-1 activity in the hemothorax fluid. So you can see that with our third line on that graph there being almost nothing. So when the hemothorax fluid is treated with a low dose of TPA, very, very small, there's basically no Pi-1. All right. In addition to looking at our inflammatory markers, we also looked at the amount of plasminogen present in our samples. So we saw that our hemothorax specimens contained detectable levels of plasminogen, but there was a lot of variability. In some patients, the amount of full-length plasminogen was minimal, indicating a potential depletion of functional plasminogen. When compared to the plasminogen band in the healthy patients, which we can kind of see in the middle. Sorry, thank you. Sorry. Plasma, I'm saying the wrong thing. Sorry. So when compared to the healthy plasma sample, which was diluted 4-fold in comparison to our hemothorax patients, we see lower detectable levels. And then, hi. Oh, yeah, that would be helpful. Thank you. And then, moreover, we observe lower molecular weight bands on the Western blot, consistent with the breakdown of plasminogen into smaller fragments. So lots of plasminogen fragments are present in our hemothorax samples. Yes. And then this is kind of just a blown up version of those fragments. We did drop the columns that have the healthy plasma sample, but we can see that there are quite a few fragments present. Okay. When we looked at our turbidity clot lysis assays in the hemothorax samples, we saw clot lysis, which took a median time of 248 minutes if no plasminogen was present in the sample to reach 50% lysis, where if we added plasminogen to these groups, though, we saw that time significantly decreased to 166 minutes if we supplemented plasminogen back in, meaning that we're able to actually rescue that fibrinolysis process by adding back plasminogen, overcoming the deficiency that's initially caused by that inflamed environment. One thing that is interesting to note on this, though, is half of our hemothorax patients at the end of our assay without plasminogen supplementation did not lyse at all. So this is de facto that their Tmax would be 270. And I just want to highlight this because this difference we see here might actually even be bigger, but we were just limited by the length that our assay ran, which was the 270 minutes. All right. So these findings have important clinical implications. First, they confirm that retained hemothorax is a highly inflamed environment with reduced plasminogen levels leading to blunted fibrinolytic response. And then by supplementing with plasminogen, we can potentially enhance the efficacy of TPA treatment, reducing failure rates and the need for surgical intervention. So this aligns with prior research in infected pleural effusions that also show impaired fibrinolysis due to plasminogen deficiency. And this slide kind of says the same thing, but retained hemothorax is characterized by inflamed environment and plasminogen depletion, and then we can supplement and potentially improve clot lysis. And that is what I got.